Welcome to our third and last video on joint pain. Let's begin. In this lecture, we will discuss pes anserinus pain syndrome, patellofemoral pain syndrome, and ankle sprains. Here's the overview slide of the topics we are going to discuss for pes anserinus pain syndrome. Pes anserinus pain syndrome is pain at the insertion point of the conjoint tendon of the gracilis, sartorius, and semitendinosus muscles. Pes anserinus pain syndrome is not a true bursitis, despite being considered so in the past. Here you see the anatomy of the pes anserinus. The pes anserinus is the conjoint tendon of gracilis, sartorius, and semitendinosus muscles at the medial knee. There are several conditions which are associated with the pes anserinus pain syndrome. However, the causal relationship is not established yet. Diabetes mellitus has the strongest association with the pes anserinus pain syndrome. Female gender, obesity, osteoarthritis of the knee also predispose to this condition. Pes anserinus pain syndrome presents with medial knee pain and tenderness over the upper medial tibia. This is because the pes anserinus inserts to the upper medial tibia. Importantly, there is no local swelling or induration. Diagnosis of pes anserinus pain syndrome is primarily made by physical exam of the knee joint. A knee X-ray is performed to exclude osteoarthritis. Ultrasound or MRI can be done if swelling or induration is present. Initial management of pes anserinus pain syndrome focuses on weight loss and quadriceps strengthening exercises. NSAIDs can be used for pain control. Refractory cases are treated with local glucocorticoid injections. Now we'll talk about patellofemoral pain syndrome. Here's the overview slide of topics we're going to discuss for patellofemoral pain syndrome. Patellofemoral pain syndrome is anterior knee pain immediately behind the patella. It is common in young female athletes. Here you see the anatomy of the knee joint. Patellofemoral pain syndrome is characterized by pain immediately behind the patella, that is the space between the femur and the patella. Although the etiology of patellofemoral pain syndrome is poorly understood, it is associated with excessive running and squatting. The clinical presentation of patellofemoral pain syndrome includes subacute to chronic anterior knee pain that worsens with running, squatting, using stairs, and prolonged sitting. Diagnosis of patellofemoral pain syndrome is established primarily by a physical exam of the knee joint. Patellofemoral compression test can be performed to check for patellofemoral pain syndrome. In this test, the examiner puts the hand on the patient's knee and instructs the patient to extend the knee. This maneuver further narrows the space between the patella and femur. Therefore, worsening of pain with this test suggests patellofemoral pain syndrome. Imaging, like X-ray, is rarely done to exclude the other causes of the anterior knee pain. Management of patellofemoral pain syndrome includes quadriceps strengthening exercises and NSAIDs. Surgery can be performed in refractory cases. A 24-year-old marathon runner presents with anterior knee pain that worsens with running, squatting, and using stairs. Her pain is worsened when the examiner puts his hand on her knee and the patient is instructed to extend the knee. What's the best initial treatment for this patient's condition? The young female athlete presents with anterior knee pain that worsens with running, squatting, and using stairs. This description is consistent with patellofemoral pain syndrome. Patellofemoral pain syndrome is further suggested by the positive patellofemoral compression test. In other words, the patient's pain is worse when the examiner puts his hand on her knee and the patient is instructed to extend the knee. The best initial treatment for this syndrome includes the quadriceps strengthening exercises and NSAIDs. We will finish off the lecture by talking about ankle sprains. Here's the overview slide of topics we're going to discuss. An ankle sprain is the acute stretching or tearing of ligaments around the ankle joint due to over-inversion of the foot. There are high and low ankle sprains. A high ankle sprain is caused by damage to the anterior inferior tibiofibular ligament. A low ankle sprain, on the other hand, is caused by damage to the anterior talofibular ligament. The anterior talofibular ligament is the most commonly damaged ligament in an ankle sprain. Here you see an illustration of the ankle joint and the ligaments around it. As we already explained, the most commonly damaged ligament in ankle sprain is the anterior talofibular ligament. However, the anterior inferior tibiofibular ligament may also be damaged in the high ankle sprain. An ankle sprain is usually characterized by ankle pain and swelling. The patient may have difficulty walking. There is usually no erythema because an ankle sprain is not an inflammatory or infectious condition. Diagnosis of an ankle sprain starts with a physical exam of the ankle joint. Let's briefly talk about Ottawa ankle rules for suspected ankle fractures, which should be on your differential diagnosis in a patient who comes in with ankle sprain. An ankle X-ray is only required if the patient has pain in the malleolar zone and tenderness at the posterior margin of either the medial or lateral malleolus. Another criteria for performing ankle x-ray is the inability of the patient to bear weight through 4 steps, specifically 2 on each leg. The presence of any of these 3 criteria along with pain in the malleolar zone makes the patient eligible for ankle x-ray because these signs indicate ankle fracture rather than ankle sprain. Management of an ankle sprain consists of the RICE therapy. R stands for rest, while I stands for ice. C stands for elastic compression to control swelling. Finally, E stands for leg elevation. A 27-year-old marathon runner presents with left ankle sprain. He twisted his ankle yesterday while training for a marathon. The physical exam reveals ankle swelling without erythema or warmth. Ankle x-ray reveals no fracture. The patient is diagnosed with an ankle sprain. What's the best treatment for the patient's condition? The patient presents with left ankle pain after twisting his ankle. Physical exam reveals ankle swelling without erythema or warmth. Ankle x-ray reveals no fracture. The patient is diagnosed with an ankle sprain. The best treatment for ankle sprain is the RICE therapy, which includes rest, ice, elastic compression, and leg elevation. Here's a table summarizing pes Anserinus pain syndrome, patellofemoral pain syndrome, and ankle sprain. Please pause the video to take a moment to consider this table. A 47-year-old man comes to the physician due to left knee pain for the past 6 months. Pain is dull and intermittent. His past medical history includes obesity and type 2 diabetes mellitus diagnosed 5 years ago. He used to be a marathon runner in his 20s. His vital signs are unremarkable. Physical exam reveals tenderness over the medial knee and upper medial tibia. There is no swelling, erythema, or warmth. Valgus force on the knee does not result in excessive abduction of the shin. Which of the following is the most likely diagnosis? A. Patellofemoral pain syndrome. B. Pes Anserinus pain syndrome. C. Prepatellar bursitis. D. Medial collateral ligament tear. This middle-aged man with obesity and type 2 diabetes mellitus presents with tenderness over the medial knee and upper medial tibia. There's no swelling, erythema, or warmth, making inflammation unlikely. Considering his comorbidities and the nature of the knee pain, the most likely diagnosis in this patient is Pes Anserinus pain syndrome. Pes Anserinus pain syndrome is an overuse injury at the insertion point of the tendons of gracilis, sartorius, and semitendinosus muscles. It's common in patients with obesity and type 2 diabetes mellitus. Therefore, the correct answer is option B. Here's a slide comparing the key features of Pes Anserinus pain syndrome, patellofemoral pain syndrome, and ankle sprains. Let's discuss why other options are incorrect. Option A is incorrect because patellofemoral pain syndrome is characterized by anterior rather than medial knee pain, exacerbated by sitting, squatting, and climbing the stairs. Additionally, it's more common in young female athletes. Option C, prepatellar bursitis, is incorrect because it's characterized by anterior knee pain along with swelling and erythema. This patient has no swelling or erythema. And finally, option D is incorrect because the medial collateral ligament tear is associated with the medial knee pain along with excessive shin abduction upon valgus stress. In this patient, valgus force on the knee does not result in excessive abduction of the shin. And that concludes our lecture on Pes Anserinus pain syndrome, patellofemoral pain syndrome, and ankle sprains.